Hi, everybody, and thank you for joining us for today's webinar. We're here to talk about telehealth virtual smart rooms. This event today is being recorded and will be posted on the website at a later date. At the completion of this webinar today, there will be a survey link put in the chat should you want the slides or ACHE qualified credit. I'm Mike Rowland, telehealth specialist with the National Rural Health Resource Center, who's providing this webinar today. Your audio is muted by default. To avoid any background noise or feedback, please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left-hand corner of your screen. If you dialed in, it'll be *6 to unmute your line.
I can barely hear you.
Oh, okay. Try to scoot up a little bit. Anybody else having trouble hearing me?
I can hear you fine.
Okay, sorry. I'll still try to talk a little bit louder. Sorry. Okay, Caleb, you can go to the, oh, you went to the next. Okay, so the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is a TA provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Okay, so as I mentioned before, I'm Mike Rowland, telehealth specialist with the DRCHSD. I want to introduce our guest speaker for today, Jessica Duke. Jessica is a senior director at Huron Consulting Group with a background in both telehealth and virtual nursing. Jess is a nurse by training, and she leverages her current and past skill set to work with both small and large-scale institutions on telehealth, virtual nursing, and digital health implementation projects, including many of those created and fostered through the Delta program. Welcome, Jess. I'm going to let you take over now.
All right, perfect. Hi, everyone. Great to be here and love talking about this subject. So thinking about our learning objectives today, I'd like to provide you all with an overview of smart hospital technology and what that means in our current market and what the solutions look like. We're also going to talk through some benefits of virtual nursing and where other organizations have found some success. And then, like Mike alluded to, we'll have the peer share component here. And where other organizations within the Delta program have had their journey with smart hospital and virtual nursing. So without further ado, let's get started. And we'll go to the next slide. Okay, so level setting on smart hospital technology. What are we trying to achieve with this? Well, certainly we want to enhance care delivery. We want to think about how to improve quality and experience for patients. We want to reduce costs, and we want to think about how to optimize workforce capabilities. So diving a little bit further into these areas, when we think about workforce shortages and burnout, folks, this isn't going anywhere. And if anything, the risk of this is increasing. And some of the characteristics here are because of our aging workforce. And I'm sure you all have maybe a little bit knowledge of this because I've talked to many of you already. But we've also hear through our assessments that there's some resistance to technology, even AI and automation within different organizations. Another area to consider when we talk through smart hospital technology is the complex technical ecosystem. And what this means is a lot of IT shops have dozens of different types of products. And this can cause a challenge as you look towards trying to integrate these different solutions. And then there's also the piece of an ever-changing IT technology ecosystem, right? I feel like every time you read a different article, it's telling you about something else that you need to consider. And then we're also reliant on end users and how they're using and how they're adopting these different types of technologies. And then we think about organizational alignment strategy. This is a key component when we think towards the new smart room technology. We have to have an alignment within the organizational strategy when we think about current and future technology investments, because without that, Mike and I have talked about this many times, you fall prey to the latest shiny object syndrome. And what this is really thinking through, let me give you a scenario. You go to a conference, right? And I've done it. I know Mike's done it. We walked through the conference floor. We looked at all the great new products, and you're wowed, right? You see the latest and greatest of a virtual care platform or RPM, remote patient monitoring, and you think, oh, this is going to solve all my problems, right? And you bring it back, you implement it, and then a year later, somebody else comes with a new product to the floor, and then you think, well, I just invested in that. So you fell prey to that shiny object. So the other area to think about is the power of the consumer. I really think that we have, as a society, think about how we shop on Amazon. We think about other big boxes and what they've done in the virtual space. Our consumers have grown to demand a personal, engaged, transparent experience. And if they don't get it from you, they certainly are going to go get it someplace else because they are in control. They are in the driver's seat of their care. So they will shop around. And that's not just limited to a metropolitan area. That's in the rural health space as well. They know how to look at reviews and they will find where they want to get their care. But I think it's also important to state that organizations can grow their market share by having a high quality personalized patient experience. So if we move to the next slide, I'd like to dig a little bit more into the capabilities of hospital. So some of the benefits here, we're talking about improved provider and staff satisfaction. And we're doing this through administrative efficiencies and time savings. And then the cost savings and increased capacity is through operational efficiencies. And then the overall improvement is over the patient outcome and experience, which is always a win. Some examples from health systems we've worked with where we're seeing benefits is increased physician satisfaction, nurse turnover rates. That's a pretty common one that we're seeing. Staff workload, hours saved. That's a big one. And that's through those administrative tasks. Reduced wait times by finding those efficiencies, reduced readmission rates, operating costs is another one. And then certainly compliance. That we're seeing this with post-discharge compliance by having like a virtual nurse that's supplying the discharge instructions and is able to spend a little bit more time educating the patient. Caleb, if we can go to the next slide, let's look at some of the technology capabilities. So this is one organization that I've worked with implementing multiple pieces of smart room technology into a space. So they started with patient engagement, which is going to be on, I think it's my left side, hopefully it's yours as well. So this is just the TV, right? They're giving them the streaming capabilities. So they could choose their, like how they stream, whether it's Netflix, Hulu, whatever their streaming service is. And then they went to an urgent patient request. So this is their call bell system, how they have the patient being able to request things, and that call goes directly to the nurse versus looping it into the secretary. And then they have a triage capability. A non-urgent patient request. So this is a tablet that is right next to the patient that can streamline whether the patient is requesting a pillow or dietary needs or whatever it is. That is migrating the non-urgent patient request to maybe the PCT or the CNA. And then you have the staff badge system. So this is where the badges have the RTLS or the real-time location system, but also has staff duress. We have seen a lot of articles. I know you guys are seeing it as well, where nurses are being attacked. So this is helping with nurses feeling safer in their space. Digital whiteboards, you'll hear a little bit more about this later, but what this particular client was doing is having that real-time data that's connected to the EHR system, is relaying information that is pertinent to the patient care and having it front and center because it's real-time information and data to the care of the patient. Plus giving the patient, hey, you have a procedure coming up. You're going down to CT to get a scan this afternoon. So or PT is coming to see you for treatment this afternoon. But all that is right in front of the patient. So patient and family knows what's going on. On-the-go clinical documentation is allowing the nursing staff to have a mobile application for the EHR so they could do documentation right at the bedside. So once again, it's correlating back to the digital whiteboard and giving them that real-time information and not waiting for later documentation. Inpatient portal access. This is kind of interesting. So instead of having the the way we used to look at the portal, where it was more in the ambulatory focus, this is giving the portal access at the bedside so that patients, if the doc is releasing maybe like an H&P or their lab and rad results, they could see it in the inpatient setting as well. And then the interpreter services, this is integrating with maybe the virtual care platform, or actually bedside nurses could use it as well, but it's giving a face-to-face as well as what we used to use with just the verbal communication for interpreter services. It also is opening up multiple other languages. Smart hand sanitizer. So this is smart in a couple ways. So the smart hand sanitizer is notifying EVS when the Perel or whatever the brand is empty, but it's also interesting because it's tracking, it's giving metrics, and it's saying how often it's being used. It's saying if it's connected to the RTLS system, it's saying who is using it and how often they're washing their hands. So you can track if you're having maybe an increase in nosocomials or whatever it may be. So that is kind of smart. No pun intended. The virtual care platform with ambient intelligence. So this is the big kicker that's really helping, a lot of use cases here. So it could be with your virtual nursing, it could be with your telesitter, it can be with your even your telehealth for your different visits with your specialty providers. Couldn't get it out my mouth. So this is something that's really elevating the care that's being delivered in the inpatient setting. And then when you tag it in with the ambient intelligence, that's giving you the sensors in the room. We'll talk a little bit more about this in a little bit. And then smart IV pumps. So this is nothing too new in the space, but they're just taking it to another level, having it integrated with your EHR system, giving you more real-time data for like your flow of your IV pumps and more integration. So take some of the documentation off of the nursing staff. So this is a lot for one room, but that's a lot of smart technology that's happening. So we'll float to the next slide and start looking at some scenarios or examples from organizations. And what I really want you to take out of the next 3 slides is for the rule space, there's different ways of approaching all of these for smart room technology. And not one of them is right. It's just what's right for your organization. So this is a critical access hospital that has a management agreement that's connected to a larger organization, right? Their decisions are made in partnership between the CAW and the management team. And so they do have care that's acute care, emergency, primary care, and specialty. And their technology services are supported from the larger institution, and they also provide them with an EHR. So the larger health system is planning to implement smart room technology to all the hospitals. So kind of what do we think? Where should they go? What would be the recommendation or questions they should be asking from the call perspective? I would definitely tell them they need to ask about the strategy. Where from the larger institution, what's the strategy? What's the strategic goals they're trying to achieve by implementing the smart room technology? What are they trying to solve for? Are they trying to solve for workforce challenges or a cost reduction perspective? And then my other thought process is at the call level, are there any concerns from the infrastructure perspective? Trying to mitigate that bright, shiny object, what, before we even get to implementing any technology, where do we need to be prepared to implement anything? Is there any infrastructure challenges we need to meet first? And then my next train of thought would be, what's the downtime of the rooms to implement that new technology that's coming into play? Is there any challenges that we may face with that downtime? And then the next piece, being a nurse by background, my thought would be, how is this going to impact the care delivery model that we currently have in place? If the larger institution is going to support the new care via smart hospital, are they going to mess with our staffing ratios? Are they going to improve? Are they going to expect us to take a higher volume of patients? What exactly does that mean if it's going to be a trickle-down effect? So just some food for thought to think through. And then, so if we move to the next slide, I have a little bit of a different example. This is a short-term acute care with no formal affiliations or agreements, and the organization has a challenge with low census and difficulty maintaining clinical staff. They do have a leadership team that has a CEO, COO, and CNO, and so their decisions for new programs or innovations require board approval, which I think is pretty consistent. And so they have patient care services in the acute care emergency, but they do not have any ambulatory services. And their IT team is a little limited, so they only have an IT director and an IT analyst, which sometimes is kind of consistent for a lot of the rural hospitals we talk to. But they do want to explore smart room technology, which I don't think is off the table. One of the first things I would definitely recommend for this organization is to start with a steering committee. I would pull a team together that is across the care continuum, for the services they provide. And then I would bring almost like pulling together a think tank to say, okay, what are we trying to achieve? And let's define our strategic goals for this. What are we trying to solve for? Are we trying to solve for workforce challenges? Are we trying to grow our market shares? What's our strategy? What is our strategic goals? And then next, I would definitely think they need to engage their board, because they don't want to just go run with this and not have board approval, it sounds like to me. And then, as I said previously, we need to talk about the IT infrastructure. We don't want to make large investments if we don't have the infrastructure to support things like this. And then the other piece of this, from what I'm understanding on this organization, is they probably want to start with a pilot, or they want to start with something that is small to see how well it is adopted within their organization or how successful they're going to be, because they can always grow from there. They may want to consider doing, either taking it to just a couple rooms or even a cart concept. And we've seen this be successful, because then you can gear from there or build out from there. And that's a smaller investment. And then you're not, if you don't feel like you can't find the ROI from it, then you're not on the hook for like a 20-room implementation, right? So that's the approach for example number 2. And we'll move to example number 3. Okay, so leaders of this call are in the planning phase for a new hospital. So definitely different for this call. They are looking to future proof. So I'm going to hit the pause button here real quick, and let's talk through future proofing. What does this mean? So future proofing means leveraging technology. And when I talk about the technology here, I'm talking about AI, or even Internet of Things. And so AI could be for like predicting complications within the patient realm, or using AI for tailoring your treatment plan. And then when I talk about Internet of Things, we're talking about real-time monitoring or using data for immediate treatment plans. So you have things within the patient room setting that is going to gather data and is going to be interpreted to give back to the care team for real immediate interpretation. Okay. So future proofing is allowing you to use technology quick and immediate for responses. And then also the other piece of this would be for using big data to optimize your operations. But the overall goal here is much like what we were talking about with Smart Hospital, is to improve care, to enhance efficiencies, but you want to create a resilient patient-centric healthcare organization or healthcare institution and ecosystem. So what they're trying to do here is they're looking to define what is needed to implement that smart technology, right? So their key stakeholders and leaders are designing strategies for the organization to advance these new technologies. They want to evolve with patient needs and withstand the evolution of the market. Sounds right with future proofing. Their services are acute care, emergency, primary care, specialty care. Their technology support is interesting though, because they are third party supported. So they don't have their own internal IT. infrastructure. So where do we go from here? What would I definitely encourage them if they're building a new hospital, so they're going to be building fresh start someplace else. I would definitely, once again, I feel redundant saying this, but I would think about strategic goals. So how does that organization want to redefine or define the care they can deliver in the market? And I would kind of want them to sit down and really think through what are they trying to solve for with this new technology, because that's really going to inform how they could future-proof that organization. Because if they're wanting to really get in depth, like that wheel I showed you with all the pieces and parts, because that's going to inform how they would future-proof that new hospital. So it may be that they need to think about how many plugs they put on the wall or how many ports they have within that wall. And I say that because I am working on an implementation actually next week that they didn't have enough plugs for all the technology they wanted to put in place. So that's why if they can come out with their strategic goals and with their strategic plan on what technology you want to put in, then they can future-proof it. And so even if you don't use all the plugs right now, at least you have planned for it. And then also think through that technology support piece. Yes, you have a third party that is providing that support now, but is that the right partner moving forward for that implementation of Smart Hospital? I think there needs to be some real conversations to say, will they be the right partner moving forward? And then the other piece I want to think through is integration, because as you move forward with Smart Hospital for your new hospital, what integration do you want? And then I would also want to talk about their EHR system. If you're moving forward with a smart hospital and you have all this new technology, how all is it going to be talking? Because integration is key as well. Okay. If we move to the next slide, I want to just give a little glimpse into how other pieces and parts can work together. So this is much like the slide I showed you earlier, but there's a little extra here. So we have that patient engagement I talked to you earlier. You have your urgent, non-urgent request, and then the virtual care platform with AI technology. But I've added in, you have the proximity sensors. So the proximity sensors are what are laid within the room, and that is working off that ambient technology that correlates back to your virtual care platform. But you also can have virtual or your voice activated assistants. So this can be where the patient would activate, like let's say Alexa, and say, hey, Alexa, can you order my dinner tray? Or hey, Alexa, turn down the thermostat or close the blinds. I've seen in one organization. Ambient clinical intelligence. This is, some of you may have already heard of this. This is where the one system or software is able to pick up on the clinical documentation and document it within the chart. There also have sensors when the room can pick up when somebody's washing their hands and have that documentation within the chart. And then the staff duress with RTLS, and then also your digital whiteboard, and then the on-the-go clinical documentation. All these pieces and parts help build into the use cases that you've selected within your strategic planning. And that's why strategic planning is so important. Let's slide into the next slide around virtual nursing, because this is one of the use cases that's pretty commonly selected when we start doing our strategic planning. So when we talk about virtual nursing, we're saying that we're leveraging technology to provide remote nursing care. When I say remote, that can be within the nursing unit. It can be at a different setting or they're in the home setting. But they're supporting and monitoring patients. They're giving documentation support, clinical support. They can be training and mentoring other nurses, and certainly patient education. We'll go to the next slide, Caleb. Okay, so what are we solving for here? Once again, this is about workforce shortages or challenges. And then we're looking at those administrative support. We're looking at the remote monitoring. A lot of times this is kind of paired up with that virtual sitter capability. I've seen organizations that had a virtual sitter program and morphed it into a virtual nursing program because they were able to do both with one solution. So the big benefit here is the reduction in burnout, improve staff retention, enhance patient safety, and increase efficiencies, and better resource allocation for sure. So we'll go to the next slide. I like to always think about the myths and the facts, right? One of the big things I hear in most of the conversations about virtual nursing is you're replacing traditional in-person care. And I have to say, I feel like a myth buster right now, and that is not true. If anything, you are enhancing in-person care. And you're doing this because you're creating a partnership between two nurses. You're giving two for the price of one, basically. What's different here is the virtual nurse is task based. They are taking away the administrative tasks for the bedside nurse and they're supplementing in. So you're giving additional support to that bedside nurse by doing documentation or coordination tasks. So it's not replacing any traditional bedside nurse. You still have your bedside nurses that are doing the in-person care, the hands-on care. So they're supplementing in. They're giving a better overall patient experience. So there's my Mythbuster moment right there. I used to love that show. So we'll go to the next slide. So other benefits that we're seeing that's coming out of here is, like I said earlier, certainly the staff turnover rate. And I'm even seeing the staff turnover rate with the first year nurses. They feel better supported because of that that senior nurse that is able to be there to help them walk them through like procedures that they don't feel completely confident in. That's another stat that we're seeing. Nurse vacancies has decreased. The discharge event time, even the quality. So patient falls, like I was talking about earlier with the virtual sitter, that's another stat that we've seen a lot in experience. So a lot of great stats that are coming out, and I think there's a lot more to come because there's not just a lot of research yet here because it's still something that just has been rolling out of COVID. So slide to the next one.
I'm sorry, Jess, did you say next slide?
Yes, please. I
Your
didn't
audio's
say it
cutting out a
correctly.
little bit.
Yeah, next slide. Perfect. So another myth. We hear this very often between telehealth, digital health, and certainly virtual nursing is that the elderly will struggle to adopt new technology or virtual nursing. And yes, it can be a challenge, but I think one of the biggest things to think about is adoption is possible. We just need to support them with education and accessible design. And how this is created is overcoming the barriers, assessing and overcoming, developing the plan that can definitely meet them where they're at. And we've seen huge advantages with programs like virtual nursing for the elderly, particularly when you have it with the smart room technology as well. Next slide, please. Okay, so what are some key considerations for implementation? One is definitely the use case selection. Have to take in consideration what you want to do with virtual nursing. Yes, virtual nursing is a big piece of it, but how do you want to utilize it? We've seen admission assessments, we've seen discharge, pain reassessment, we've seen high alert medication co-signing, but then there's also so much more you can do with it. Where I've actually seen it implemented most often is you start with those like 4 core and then let your nurses start to brainstorm. Let them start thinking about how. I worked with a team just the other day to the nurses just sat and really thought through, okay, what's our documentation heavy areas? And one of them was end of life documentation. I never would have thought that that would have been an area that they thought they could plug in the virtual nurses, but it was very important for them. It was the ICU And so we just sat there and built out the workflow for it, and it was a huge win for them. So wherever documentation can be lifted and taken off of them as a burden, that's where you're going to find success. Another one is the technical considerations. Think about what's the infrastructure, what's the technology that's going to need to facilitate. Do you currently have the technology? Could you repurpose what you're using maybe for any telehealth and then think through how to implement? The care models and workflow design. It's not necessarily something that you can just take your current state. You need to really take into consider the care model piece of it. Working with another organization, we level set what's our current care model. If you have a primary nurse care model, do you need to think about how to change it? Do you need a flex between two care models? And then how do you take the virtual nurse and plug her into your current care model? What's the roles and responsibilities and how do they get redefined? Do you have to adjust your job description? There's a lot of considerations within the care model. And then the workflow design, mapping out from start to finish. How do you adjust and how do you assign the tasks between the two is very important when it comes to the workflow design. Same with staffing models, that kind of flows between the care model and staffing models. And it can be a sensitive subject when you start talking about your staffing ratios. And it's hard for people to understand that the staffing ratio may not adjust because this is task-based, but you still want to account for that nurse. And then implementation planning. Certainly understand how you're going to get this lifted and move forward with it. And it's not just technology and it's not just nursing. It's definitely across both areas and should be supported that way. Okay. Of course, my yard guy shows up right now. Go to the next slide. Okay.
Okay. Well, leaf blower aside, I think that's really great. Thank you so much, Jess. Caleb, you can go ahead and go to the next slide. So as I said, thanks, Jess, so much for that great overview. There were some questions and thought process in that I actually didn't even think about until you said it, even though we've kind of lived through implementation stages for a while with some of these teams. The next thing we want to do is we want to take a dive into a peer sharing session. So kind of the awesome component of this webinar was that we have two fantastic teams that have already done a lot of the legwork and done the virtual smart room build outs at their own institutions. And I want to make sure that we got to tell their story because they worked their butts off in order to get to this space and be able to implement all these massive changes to their organizations. So the first team I want to introduce is St. James Parish Hospital. They graduated from the Delta program in 2021. On the call with us, we have CEO Mary Ellen Pratt, IT Director Darren Donaldson, and Director of Nursing Rhonda Zeringue. They'll be sharing their journey with virtual smart rooms. And in addition, we also have the second team, Lawrence Memorial Hospital. Joining us are CEO Aaron Hilton, RHC Manager Carol Rogers, Chief Nursing Officer Rachel Rouse, and IT Director Josh Wise. Plus, we also have a special guest, former CEO Josh Conley, who led the Lawrence team through much of the launch phase for virtual smart rooms. Aaron Hilton is now the current CEO and oversees the program and its expansion. All right, Caleb, you can go to the next slide. Okay, so for this panel discussion, I just want to dive into our first question for both teams. Could you please describe your general virtual smart room setup, including the specific technologies and equipment that you implemented? Also, if you could talk about how you decided on the layout and design of the rooms and what steps you took to ensure that integrating various systems like telehealth, EHR, and communication tools were taken. Does anybody want to start? Totally open. Which team wants to start?
We can go first.
Okay, sounds good.
Can you hear us okay?
Yeah, we can.
Good. My name's Darren Donaldson. We represent St. James Parish Hospital.
I'm Rhonda Zeringue, Chief Nursing Officer.
I'm the Director of IT, and I was kind of like the project manager on the implementation. it really kind of came from an original budget idea of us having to replace our nurse call. And from there, we kind of took it and wanted to look at options. So had this massive investment, and while we were doing it, we kind of wanted to see what was out there in terms of technology, virtualizing rooms, making things smarter, and that's kind of how we got to be where we are today. Our project really was kind of like threefold. The first one was replace a nurse call, which that in and of itself kind of had it made us smarter in the sense that it went from like almost a walkie-talkie two-way communication system to something that involves servers and reporting modules. So we were now able to get call data, quality was involved because now we could see like response times and stuff like that. The second part of the project was replacing our dry erase boards with stagnant old info that required humans to have to erase it and always keep it up to date. So it wasn't real time, to a smart digital board in the rooms in the form of a 50-inch TV that was oriented in a vertical way that displayed key components of our clinical team, the doctor, obviously, active orders in the system, tasks that were coming, to keep all parts of our clinical team and the patients and the family members on track of what was going on in a real-time setup. That required integration to our EHR so that we don't double work. We didn't want to have to go put stuff in to the digital board. We want it come in real time from our EHR. So we had to integrate Cerner to our nurse call platform for a digital board. And then the third piece was, while we were doing all this and we had the boards, let's fit key patient rooms in acute care with virtual tele capability. So we chose 10 rooms to start, and we fitted those with all the audio, video, and cloud tele platforms to where we can engage family, visitors. We could do clinical care from specialists, consulting. We could get our hospitalists and our rounding involved. We could do ICP with other, it kind of just goes from there on how you want to use this virtual clinical care team.
Great, thanks, Darren. That's really that great detailed description. Lawrence team, would you want to chip in and tell us a little bit more about your build?
Yeah, I can jump in. In example one of Jess's conversation about the management agreement on a hospital, Lawrence is that example. So our mothership hospital had already been trialing this technology of virtual rooms. So we got to leverage some of the lessons learned there. But with that, we at Lawrence were the first to look at that at a regional level. So again, going back to some of the notes on infrastructure that was out there, I know we'll touch on those later, but our general rooms, we had carts throughout COVID, but they want to take it a step further to an in-room smart room setup. So have a TV there as well as a camera, and then interactions with that with all of the we don't have any of the boards just yet, but that's on the radar for future integrations as we talk with our vendor. So very similar setup.
That's wonderful. Thanks, Josh, for that deep dive. Caleb, let's go to our next slide. So the next question I have for you is, during your build, did you encounter any unexpected challenges or surprises, such as technical difficulties that required innovative solutions, or resistance or concerns from your staff or patients? And then last piece is any kind of logistical or infrastructure challenges you ran into. I do want to chip in one thing because Jess had me thinking about something during her presentation. And one of them is how, if you wouldn't mind answering this, how long were your rooms down while the infrastructure was being built out? So I know a lot of that isn't super deep whenever it's just a TV on the wall, but there's a lot of wiring that probably needs to be, implemented in order to get it done. So think that's another piece of infrastructure we don't always think about. Josh, would you mind hopping on this question here?
Yeah, we'll do. Start on just that last question there. So Josh Wise on here, IT director at Lawrence, and phenomenal job by him and our engineering team, where our rooms weren't down per se because we kind of rolled it in rooms as we could move patients throughout the med-surg floor. So we had very limited downtime. We kind of got everything ready, got a plan, and then boom, implement it, and did it methodical fashion there. But some unexpected challenges on us. Like I mentioned, there's a management agreement where we share and leverage the same EHR with our tertiary mothership, but it's just a management agreement. So there has to be firewalls and different environments, and all there is to that is compliance, HIPAA, risk management pieces. So we didn't recognize that until later in the game. So we were, getting close where the infrastructure or the physical infrastructure was there and ready. And then we said, oh, we need to take a step back and work with our vendor and IT folks, and had to build a separate environment, is the best way to say it. And then, of course, since there is that separation, the virtual nursing component that is done through our anchor location, having the compliance and correct legal documents, whatnot, so that people get into each other's systems and do it in a way that would not be flagged by any governmental system or governmental bodies or compliance folks. So from an infrastructure build, that was kind of the aha moment along the way, but we're limited in our downtime. And I'd say the change management piece on that side with employees and with our staff providers, we made this a mission imperative from the executive level on down. At the time, I was very closely monitoring this project, and probably more involved than I was any project at Lawrence, because strategically, to Jessica's points, this was a imperative for us to do for numerous reasons. So we all work together to make it happen.
That's awesome. I think that's really imperative. That change management aspect is really, it's a feather in the cap to think about that as being high priority. Actually, I have a great question, kind of similar to what we were just talking about with change management. The St. James Parish crew, you all really set out early on when you were working on your virtual smart room build out. You really project planned and set, great goals. You were really good cheerleaders for this, but you also have to work with a full hospital. So did you guys have any kind of aspects that you weren't quite ready for or didn't expect as far as coming at you with any new challenges or surprises during your build out?
I don't think we had any, I mean, for a project as big as it was, I think I was actually surprised we didn't hit as many roadblocks as what I would have thought. We staged ours, so we always kept a wing of the hospital open for inpatients. We had an overflow plan if census got large. We made sure, for wire pulls and infrastructure build, that we could pivot quickly. We made the contractors agree that we could get rooms back within, a few hours in terms of cleaning and getting the stuff out. So we definitely did that. A big thing for us was we were doing nurse call as well as the technology. So as we were ripping out old nurse call, we had to make sure we met code in terms of code blue and communication with patients and call bells, and we couldn't just leave the patients in the dark. So we had a lot of backup plans, and we very strategically had to rip the old nurse call out because, as most of you know, old nurse calls kind of daisy chained off each other. So it was very important to know how that system was way back when and rip it out strategically and kind of go in order.
One of the other things that we identified early on, it was unexpected, but the nurse manager thought about this. Like Darren said before, we chose 10 rooms to have the cameras, to have the tele platform. And we identified that if we had a patient in another room, once we put all of our use cases and policies in place, we needed a mobile platform. So Darren was able to get a mobile device and got that set up through our vendor, so that we had the capability to go anywhere with the computer.
Right, yeah, so we have a rover cart that we can push anywhere, and that really came about when we wanted to start to explore like biomed type stuff. So we wanted stethoscopes on a USB, otoscopes, and other patient peripherals that obviously wouldn't kind of work in a hardwired room environment. You don't want a stethoscope tethered to the wall. You want that on a cart that you could actually roll by a patient. So that gave us flexibility to where we could move it anywhere. And like Ron is saying, it really opened up the whole hospital to where even if somebody was in a room without tele, we could pivot that cart. Another part, I wouldn't say this is necessarily a surprise or a challenge, but it's just real life experience. When if any of you guys partner with your vendor, EHR vendor, to tie into digital boards, obviously there's going to be interfaces involved. And really, I want to encourage really challenging you guys to not accept like the status quo answers. Don't always accept, oh no, you know, we can't put diet in this interface. Well, that's not necessarily always true. So really lean on them. And what you're going to find typically is the third party who's interfacing with your EHR, they want a well-rounded product. They want something that they can sell. So even though it might not be developed or it might not be within scope today, if you guys push on them and explain the clinical need, both parties typically are going to adopt your solutions and build something brand new based off of your clinical use case. So you know, really tell, like one of the things was we didn't want the you know, we show radiology and lab orders on our digital whiteboard. We didn't really want the actual radiology name, thoracic spine. Like we just wanted it to say CT, which required common language on the whiteboard for family and patients. So, you know, that really wasn't in scope, and it wasn't until we really asked and explained and came up with this big clinical crosswalk to translate that into common language through the interface, was it adopted. And that's just one small example of that. So
yeah, that was a key part in this project too, getting the multidisciplinary team that was going to use this whiteboard for different reasons, and make sure that it was the common language and it was meaningful information that patients and families can understand. So that took a lot of time, that crosswalk build. Darren spent a lot of time, and they did a lot of testing and worked with the team to make sure, does that make sense? And that was very beneficial.
The other challenges are just normal challenges that, you know, we don't really have to talk about. We know we got to get the physicians on board and bought in. We know we got to get nurses bought in. And we kind of took the approach that if we make it super simple to use and as, you know, non-complex as possible, not requiring a lot of work for physicians or end user, the product's going to sell itself. The people using it, whether it's consulting physicians or family members or whoever else you want to engage in virtual nursing, if the product is good, you know, you don't need a lot of advertisement for it. It should organically grow on its own.
Yeah, that definitely was something when I spoke to the physicians about doing this, when they rounded or, you know, for consults, they want to make sure it's easy. They want things to flow well and not have disruption in their normal workflow. Even if it's a few minutes, it's, you know, they want it to be efficient. So it definitely was important to have a team from the beginning. I had a lot of frontline nurses and case management who was going to be using this and get their buy-in from the beginning. And we tested, you know, a lot, and also had key physicians that we started with initially.
Yeah, and you definitely want to start small. You don't want to go live on day one and have every single avenue of virtual nursing. The whiteboards is a little different. That kind of, you don't really have to do anything with that. That comes from the EHR. There's a little bit of a learning curve to, you know, just kind of management if there's a piece that's not accurate. But, you know, we also took the approach, we didn't want to start with physicians.
Right.
We did not want to make the physicians and consulting services our guinea pig. So we did a lot of internal testing with family and visitors. You know, if something messed up or something didn't work, it's a lot easier to explain to a family member, hey, this is a new product that we're testing, versus a cardiologist who's checking a patient for, you know, a follow-up appointment who's admitted to a hospital. You don't want that call to go bad. So we started with the least critical part of the virtual telehealth, and then worked our way up to all of our service lines.
Right.
Well, I think one thing that should be said is that both of your teams, Lawrence, St. James, you've both had a champion mindset. You've pushed hard for this, and it shows. You guys have seen, you know, you're able to really retrace your trajectories from the start, and it's commendable that you've been able to kind of see these babies grow and get bigger. And I think that, you know, it's wonderful that you're able to come and share with us. We really, really appreciate it. Caleb, I want to go to one more slide here. I actually want to skip the use cases, and I just want to go to that lessons learned. Any other kind of takeaways or big questions that, you know, or big thoughts that you want to make sure that the crowd knows before they plan out? Obviously, you guys have talked about how granular virtual smart rooms can be, you know, from the wiring components, you know, how invested you have to be into the room structure. But are there any other aspects that you want as a takeaway or a nugget of knowledge before some of these other Delta cohorts take up the cause and look at virtual smart room build outs at their own hospitals?
I think I'll say, and I kind of said it before, but having a team and, you know, stating the why and getting the buy-in from the beginning, getting them involved in the build and, you know, all the things that all the decisions we had to make for it, having them involved was key. And the reason is because it's very easy to do. Like Darren said, it's very easy, but it's easy not to do it as well.
Yeah.
So you have to stay on it. So I kept saying that to the team, like, this is very easy, told them the benefits, the why, and got them in from the beginning. But listen, if you're not watching the metrics every month, it is easy not to do this, even though it's easy to do. It's easy not to do as well. So you have to monitor things monthly and report it out, and, you know, stay on and have like some structure in place on how you're gonna do these virtual visits and connections.
Yeah, I'll echo the exact same thing. It's one of the strategies. If anybody had any kind of Six Sigma training, the sustain phase at the end is typically the hardest. So anytime, you know, you're transferring a project either from IT or admin to the frontline staff, monthly metrics, like detailed, transparent reporting that is discussed with the staff. The minute like you think you can take your foot off the gas and hand this project over, I mean, we were seeing in the hundreds of consults, and we thought, oh man, this is great. Month after month, we were hitting our metrics, which is also a thing to have in your management plan from your upper leadership. Hey, these are the numbers that we want to try to hit year one. I mean, the minute, you know, Rhonda and I and the acute director thought maybe we could back off, you see those numbers dip. It's just a natural, organic thing. So stand on it until it becomes part of your daily process, until it becomes hardwired, was vital to me, because I saw the opportunity that if management backs off and there's no metrics, it could easily be one of those things that you just spent all of this money and time and not really using it, because I mean, hospital care goes on without it. So it really needs to be utilized and added, hardwired into your daily processes.
And the other thing we have also done in the nursing department, besides these metrics and monitoring it, is I often do rounding on patients. You know, we do the student principals and we round, and I discuss the whole, you know, make sure that they were informed about the capabilities that we have with the tele visits and virtual platforms. So sometimes I go in a room and they like might not know about it. So we created pamphlets and made sure that patients are educated from the beginning whenever they're admitted. So it's all patients that are admitted are educated on the capabilities that we have and all of our use cases.
And that's from the patient side. The physician side also gets a lot more traction than you would think. When we brought it up to our cardiology group, they jumped on it. We had nephrology who didn't even know about it,
Yeah.
and they just so happened to see cameras in the room while rounding, and they asked about it. And so, yeah, in general, it's as long as you talk to them beforehand and have a plan, the physician groups are very open to it.
Yes.
Yeah, and I would echo every bit of that, with only a few more story to tell. Is that, you know, one of our ED providers, who we track to see if his admission rates, you know, why was he not admitting as much as our others, and, you know, was it different patient loads? And he made the comment that, well, I know these patients will be transferred eventually to a higher level of care. And then I said, well, have you heard about our cameras, you know, our smart rooms? He said, no, I haven't. This is when they were just installed. And I said, well, walk with me. And we walked to the room, and I said, here's what this can do, and explain virtual nursing, explain specialty consults coming up, explain dietitian consult, explained all the patient, you know, just items that could be done. He said, this is great. I'll keep people here now. And that is why we did it, to keep our patients at a local level where we can increase capacity and capability at our regional hospitals, and then also help the system as a whole to get the right care, the right place at the right time. And he got it then. And it was like, all right.
Y'all know that there are marketing people out there, right? That do. I'm kidding. No, it's wonderful. And I think it's the proof is in the pudding. Whenever you have that real time perspective, whenever they're really able to see it, you know, I think that clinicians really are able to attach to something that they see utility in. We hear, you know, Rhonda and Darren, you were talking about this before. We hear often, you know, the apprehension behind clinicians and using telehealth products. And a lot of it is just to get to the start. Once they use a product 1-2 times, mostly when it's a clean transition from one space to another, it's pretty simplistic and it's used over and over again. But it's always that transition of starting to use the product that is the hardest piece. It's like journey of 1,000 miles starts with a, you know, single step kind of thing. Anyway, well, that's pretty much all we have time for today. Caleb, I will mute out here, so I know you want to launch the polling, and yeah, there's some stuff to wrap up. So,
Thank you to everyone who showed up today. Thank you, Jess, and all of our speakers, all of the panelists. Instead of polling, I put in the chat, you will see a survey link. You don't have to fill it out, but if you would like the slides or qualified ACHE credit, please make sure to at least copy that link or open it for later. Yeah, otherwise, that's all that we have for us right now. Jess, Mike, Josh, St. James, do you have any final words?
I would just say big thank you to everyone that helped put together this call. This call's been like 6 months in the making, and I really wanted to make sure that we could both have Jess's expert opinion on the call and also have you know, the great teams at Lawrence and St. James, because as I said before, they really worked hard to get to this point, and there's a lot of merit in the work that they're doing. So thank you so much to those crews. And if you have questions about virtual smart rooms, virtual nursing, please don't be afraid to reach out to me. And if anything, I can forward the questions to the right people.